30 minutes, brilliant. So you've got plenty of time to go grab yourself a coffee for those people that survive on coffee, or get some sunshine if that's what's helpful for you. And then back into concurrent sessions, I think, in about half an hour's time.
This is being recorded, isn't it?
It's streaming now.
It's streaming.
So it's now streaming.
Oh, that's exciting.
Cut my hair recently.
Hello, everyone. Nice to see you for our last concurrent set of sessions today. My name's Chris Maley. I'm the chair for this session on co-design, which I'm very excited to be here to share with you all. So we've got 4 speakers. They're going to speak for 20 minutes each. We'll do questions as we go. So each speaker will do questions within their 20 minutes. This is being live streamed and perhaps even recorded. So just bear that in mind if you ask any questions that you will be on a recorded mic. So without any further ado, I'm going to hand over to Tessa and Judith. They're talking about a project that I'm working on too, actually. The title of their presentation is Research with, Not for Consumers, Reflections on Co-Designing a Qualitative Study on Physical Health for People with Mental Illness. So,
Thank you. Oh no. Oh, okay, yay. All right. So, thank you so much, everyone, for coming. So, our presentation is going to be about reflecting on the process of engaging consumers in the design of a consumer resource. So we're not going to talk so much about the resource itself, although we are running a workshop on that on Thursday at 12:30 that you're all invited to attend. But today we're just going to be talking about how consumers were engaged, when that worked and when that didn't work. So we've got co-design in our title, but many people in the consumer movement and also even in our little group believe that the standards for co-design are, like pure co-design is incredibly difficult to achieve, and we did the best that we could, and we're going to share those reflections with you so that maybe you can use them in your own projects or use them to inform kind of any initiative that you might be a part of going forward.
No, is this working? Yep. So yeah, when I agreed to do this presentation, my first words were, "But I'm not sure it is true co-design." But I think sometimes we have to be willing to walk that journey. We might not be there yet, but we're working towards it, and I think that's okay too. So yeah.
Yeah, and I'm Tessa. I'm the project manager for this bit of research. We have a co-design group of which Judith Drake, my co-presenter, is a member, and we can't wait to share it with you.
And just sorry, is Amrita here? Yeah, so she's on our co-design group, and I don't think there's anyone else from the co-design group here, but if there is she here though? I think she's at a different presentation. Yeah, cool.
Right. So the purpose of the research is to create a resource that will help improve the health gap in physical and mental health for people living with mental health concerns. So, so that's the goal.
And we're going to just assume that you understand what that gap is, because that's kind of what the entire conference is about. So we're not going to go into that.
And so the part of having, so it's a very broad kind of aim, and we weren't given much more detail than that, which is where the co-design group comes in, because they're able to kind of help fill in that detail a little bit, as well as our participants who took part in the research. Yeah, great. Did you want to say anything about that? Okay, great. So I'm going to talk about this one because I'm on the research team, so I am a consumer academic. I do have lived experience, but I don't have experience of physical health concerns, and I come from the research side, not the co-design team. So I'm going to talk about why we chose to do this co-design. And it's really because the people who we want to use this research should be the ones telling us what the research needs to do, what the resource should do. So it's, you need to actually have those people engaged for it to meet those base requirements. So that's kind of why we picked that methodology. And in doing that, the co-design group has done so much more to make the research process easier that I didn't anticipate. Like, I could come back to them with problems and say, we haven't recruited enough from this cohort, or, this has happened. And they would come up with a solution that I could then implement. And so in that way, the co-design group process has been meaningful because there's some decision-making, but also because it, kind of makes my job a little bit easier. We're doing it as a team. Do you want to read the...
We got some quotes from different people on the group. So Lynn said, it's been a process, but we've gone through bit by bit about what's necessary, what's missing, the impact that it's had on us. And if you have a short interview or a focus group, you can't work through all those issues. We've covered the stigma, discrimination, talking about it from a carer's perspective the other day. So there's a lot of detail and a lot more information that's been able to be gathered by doing it over a period of time. So we've done various things as a group. So we were involved with the literature review. So using, what's it called, Covenants?
Yeah, we use Covenants.
For any academics in the room, I was new to all this. But yeah, going through the different research, so including substantial assessment of existing resources, of which I have to say there weren't that many that made.
We identified 4 from academic literature and about 52 from grey literature.
Yeah, so also ethics application, so the development of essential study materials. So yeah, Tessa one day had me drafting a letter to recruit GPs, and I'm like, that's not something you normally do when you're on an advisory group. It's like, this is actually being involved in the project. So that was a bit new. Recruitment pathways, and I think you just talked before about, when you have trouble recruiting particular demographics. And then the initial sort of data analysis, and we've been going through doing sort of qualitative discussions of quotes and transcripts.
Oh no.
Alarm has been cancelled.
So I also have physical and mental health issues. One of the things I do to manage my physical and mental health issues is wear an emergency watch that apparently has a fall feature. Apparently waving your arms about sets off said feature. Either that or there's just something about this particular spot. That's slightly embarrassing. But anyway, over to you.
I also just wanted to share that it was actually really helpful to have the co-design group involved in all of these processes. We had something like 12,000 sources from our original literature review that needed title and abstract screening, and co-design group members probably did maybe half of that work, which meant that between all of us, we got it done. And it was much faster. It was also a real opportunity, I think, to kind of, for me, I felt like I was kind of sharing a bit of that traditional research knowledge, but also I was learning a lot from the co-design group about how it sort of didn't work, because I'd say, oh, we need to do it this way, or we need to stick to the criteria we've decided or whatever, because I wanted it to be all nice and reportable for a Q1, systematic review. I wanted that fancy publication out of it. But the co-design group were quite firm with me that wasn't really what, that didn't really prioritize the things that they saw as important. And so that was really interesting reflection for me. But also, there was a little bit of help in terms of the labour. So it was quite a nice relationship, I think.
And I'll just read a quote from Elsa, who's also on the group. I felt we were included in a fair bit of the process, which meant we learnt the focus of what was going on, and we were able to contribute at quite a few steps through the way, which was helpful.
Right, so we did have some discussions in the co-design group about why it feels close to co-design. But me and Judith were just reflecting, and I think the big one is that you guys tell me when I'm wrong, and tell us when it's not working, but in a way that's like, I don't know, like it's just really nice. Like it feels like I can respond to that effectively, and it's quite solution oriented. But I think that we're getting that feedback that things are wrong shows that the group believes that they can have a say, and that say will be taken seriously, I hope.
So I'm just going to deviate from that because I'll make it up as I go along. I was just in Kath, and I've forgotten her co-presenter's name. Oh God, I've done it again.
Stop pulling over.
Yes, all right. It's one of those days. Sorry, I was in Kath, and I've forgotten the co-presenter's name. I'm sorry, workshop earlier about co-design. And there was a lot there around power dynamics. And I was sort of just reflecting on this particular group. And I think, I wonder if having can I call you an early career academic? Is that all right?
Yeah.
Sort of coordinating the group is actually an advantage, rather than someone who's like, a crusty old academic that like, I've been doing this for 40 years, I know how to do everything. That actually you're quite willing to admit what you don't know, and some of us consumers are quite willing to share what we do know. So I don't know, I can't speak for how Tessa experiences that, but from our point of view, it does actually feel like there is a bit of give and take, and that some of that power is perhaps a bit more shared.
Yeah, we were reflecting on this, and I think one of the challenges of what we've been doing is that most of the power has rested with the research team, because we hold the resources. I'm kind of engaged on the project more regularly than the co-design group, who meet about monthly. But it's about how I then use that power that makes it collaborative. Yeah.
But we do feel able to speak up, as she will attest to.
Yeah. Oh, do you want to read the quote, or should I read this one?
You can read that one.
Okay. So this is from Judith. It has been good to be involved in things like the lit review, because you don't normally get involved in those sorts of processes. So you just get given the results, and it's kind of by magic that this kind of happened. Whereas when you're involved with it, you can sort of see it develop a bit more. There's a bit more, I don't know if ownership's the right word, but kind of ownership of the work. So I think the key obstacles in kind of cultivating a co-design type project have been resourcing and the funding requirements. The funding was co-designed, but with different consumers to the ones that are now involved in the project. And so because of that disruption in continuity, the co-design group now haven't felt that the funding requirements were co-designed by them. So that's been something that we've had to work through. Recruitment as well. So sometimes that can be an obstacle, although we actually found it quite easy.
I think we've ended up with a reasonably diverse group. I think that was possibly more by luck than by design, but yeah.
Yeah. But I think that's nice that it was by luck, because we didn't think like, oh, we need, a certain amount of, people from a coal background or a certain amount of women or whatever. It just kind of happened. So, yeah, so that's been really lovely. Yeah, and then I think also one thing that's probably been difficult for me is communicating the requirements of, like what I've written as the academic world, including in the ethics application, to the group in a way that makes them still feel empowered, that their perspective does matter because, you know, for me to get certain things through ethics, I need to abide by certain rules. Or to get in that Q1 journal, like was my dream, I need to follow certain rules, and then communicating those rules and also communicating where that's coming from. So whether that's coming from me or from, you know, or from these broader external forces, I think that actually does really matter because that impacts the trust between the group and the coordinating researchers. Yeah. Did you want to add anything?
No, I guess there are certain requirements of something being an academic publication and or process, and as consumers we're quite happy to say, but why do you do it that way? Because that's what academics do. Yeah.
Yeah, cool. So I think where it has worked has been, yeah, so as I said, putting problems back to the group and they've resolved them, which has been so, really can't underestimate how, like, that's just been incredible. Sorry, I'm going to move over here so I can see it. Yeah, and I think, yeah, kind of like that continuity. Oh, thank you. Like keeping that continuity has been really helpful because it's also helped us to build relationships where earlier on, you know, like I might have understood some people as maybe perhaps expressing some concerns, but then over time, because trust has developed, I might not experience them as concerns anymore. And also I've noticed that over time, people kind of tend to be less suspicious of me as a researcher. And that's been nice.
I think a key word there is actually time. That we've actually had quite a few meetings, and we've actually had times where we've gone, actually, no, we need more meetings, and no, you just need to kind of find the funding for this because if you want us to do this, we need to do it well. Yeah. And I think, as I say, it may not be true co-design, but if you want to call it co-design, it does actually take time, and you do actually have to be willing to invest the time into that. And I think, yeah, that's really important.
Yeah. Cool. All right. Well, look, sort of brings us to the end of the reflections that we wanted to share with you because we did want to allow some time for questions. If you're interested in the resource, please come, as I said, to the workshop at 12:30 on Thursday. It's going to be kind of an open session where we'll talk a little bit about the data we've got on it so far, but we also will want to hear from you guys, and there's, you know, we might even be able to put some of those suggestions into our broader pool of data. So, yeah, thank you very much.
Thanks so much. That was amazing. We have time for a few questions.
I didn't put your contact on.
It's all right, I can project, I think. For the online. Oh, right, yeah, oh, cool. So, really interested in when you put the co-design request out to the universe, did you have an idea of what skills the individual people with their lived experience possess? Like, were you not just looking for their, say, for their morbidities, but you know, also their particular talents, like, you know, maybe drafting or, you know, project management or something? Did you have a second view?
Look, not really. I didn't really ask people for any of that kind of background stuff. We did make sure that they identified as having a mental health and a physical health challenge, but we didn't ask for any information about that, and we never have.
Most of us do have a bit of a background in consumer advocacy, which will be different flavours for different people. But yeah, so we do have some sort of experience in different things. But we've also, we've got people who've sort of worked as like consumer consultants and people who've been on advisory groups. And so it's sort of, we've done similar stuff but different stuff, if I can put it that way.
Yeah, but we do have some people as well who this is their kind of early, you know, their kind of first consumer perspective role. So we got a mix. And I think that was partly some people we invited to, you know, we kind of directly sent the EOI out to them. And then some people were recruited, we sent it out, you know, we put it on social media, it went out through Being. And so we did get some people through that kind of public facing recruitment as well. But I'm also thinking, like, when we were inviting people, like in the early stages when we weren't sure that we were going to get enough EOIs, we were thinking across states. Like, we didn't want it to be too Victoria centric. So
What have you got against Victorians?
Yeah, well, that's because we knew because we know them, but like because we're all Victorians. But we were thinking from that perspective, but there wasn't, in terms of skills, I don't think that was a consideration.
Yeah, do you want?
I can.
Yeah.
So one of the really interesting things about this project was that when one of the lived experience members of the project, of the research team, who's doing a PhD couldn't do as much hours as we were looking for, we could then go to the co-design group, and somebody from the co-design group could move over into the research team. So that made it much more fluid than it might otherwise have been, I think, don't you? It just gave a sense of breaking down some of those barriers, yeah.
I saw a quote from a carer. So it was carers and lived experience together in the group. What percentage, do you know, were carers and people with lived experience?
So the co-design group doesn't have any carers on it. But we did interview carers as a part of the research, which I'll talk about more on Thursday. We did have trouble through that recruitment pathway. So we put it out on social media and through a few organisations. So initially, the first pathway was that we asked consumer participants to give us a contact of someone who supports them, which didn't work. Then we put it out on social media and through an organisation, which also hasn't worked. And now we're trying another way. So the carer voice has been underrepresented in this research. We've been trying so hard to make that not the case. We did exceed our targets on talking to consumers as a part of the research and clinicians as well. So I'm not sure. Yeah.
So that decision, though, about the composition of the co-design group was made because it's a resource for consumers explicitly. And so that was an intentional decision to have all consumers on a controversial decision, perhaps, but one that was intentionally made through a reflective process. Yeah. That's all we've got time for. Please join me in... Okay, just while we get the slides sorted. So next we have Lauren and Caroline talking about how to use program logic and co-design for the planning and the implementation of health interventions. Over to you two.
Hi everyone, I'm Lauren. I'm a research assistant at Mind Australia.
And I'm Carolyn. I'm the Participation and Co-Design Manager at Mind Australia and bring family care lived experience to that role.
And today we're going to talk to you about using program logic and co-design for planning and implementing a specific suite of physical health resources at Mind Australia. But before we get into that, I'll just say Mind acknowledges that Aboriginal and Torres Strait Islander peoples are the traditional custodians of the land on which we work, and we pay our respects to elders past and present. We recognise the intergenerational impact of the history of invasion, dispossession and colonisation, and are committed to the recognition, respect, inclusion and well-being of Australia's First Peoples.
Mind also values the experience and contribution of people from all cultures, genders, sexualities, bodies, abilities, spiritualities, ages and backgrounds, and we're committed to inclusion for all our clients, families and carers, employers and volunteers. And that's particularly important to remember when we're thinking about physical health. We also value the expertise and leadership of people with personal lived and living experience of mental health challenges and alcohol and other drug use, and families and carers as we work together to influence and transform the services and systems in which we work. So for those of you who aren't familiar with Mind Australia, Mind is a community managed mental health organisation that operates in 4 states in Australia, so Queensland, Victoria, South Australia and Western Australia, and we're about to commence service delivery in New South Wales in the near future. So we support people facing mental health challenges and wellbeing concerns, and we provide support to offer them help, hope and purpose in their lives. So we really focus on kind of tailoring supports to individual people and making sure that what we do is evidence informed. So we've provided recovery support to over 11,000 people in the last year. So we're committed to lived experience approaches and making sure that the people who use our services, whether they're clients or whether they're families and carers, have a say in decision making and are involved in that continuous improvement in practice over time. So we strive for meaningful participation with clients, carers and families to co-design processes and challenge biases, recognising some of the challenges in doing co-design. So last time at the Equally Well Symposium in the Gold Coast, I gave a presentation about a physical health tool that we had co-designed with our lived experience advisory team. So this was a co-design of a resource that already existed. So we had a physical health checklist that was based on questions that came from national guidelines. So we reviewed that checklist and got feedback from the clients who use our services and also our staff members, and found that there were some problems with that tool. So we went through a process of working with our lived experience advisory team to kind of workshop what the issues were and what the priorities for designing a tool would be. Then we presented that information to our community mental health practitioners, and we did a survey and a workshop to gather their perspectives. And then we reviewed the current guidelines and literature just to see kind of how the field had moved on since the original checklist was designed. Then we went back to the lived experience advisory team and we did another survey and a workshop to look at how we could bring together all of that information. And then we drafted a tool, so came up in using co-design language, came up with a prototype that we then brought back to the community mental health practitioners, and then they kind of looked at how that would work for them in practice, and we tweaked the tool to make sure that it would work in a practical sense with clients. And we also got feedback from content experts as well into some of the questions and areas, recognising that there's some nuance to this work, so particularly around eating disorders and asking questions about food and nutrition and physical activity. So this was our toolkit that we designed. So we came up with a practice guideline which goes through all of the principles that underpin the practice tools. We have a My Physical Health conversation starter. So this is an opportunity for people to choose the areas that they want to talk with their worker about, and some prompts about why those particular areas are important. And then when people, they might choose to talk about kind of sexual and reproductive health, for example, to take from Debbie's talk this morning, or they might want to talk about sleep. So they can choose those topics, and then the other pages have some questions to ask about. Then we have, if people want to set a goal around or take some action around their physical health, then we have a resource called Ideas to Explore When Setting a Goal. So these were some of the ideas that our lived experience advisory team came up with about the practical ways that of things that they can do themselves or things that their worker can help them with to support their physical health. We also created an intranet page to kind of bring all of this information together, because it was really kind of rich content that we'd heard through the workshops and surveys. And most recently, we've been creating a webinar for staff about how to have supportive conversations about physical health, recognising that physical health can be a sensitive topic for people. So we have some video interviews and things that we've from our lived experience advisory team that we've pulled into that webinar, and it explains all of the principles in much more detail and why they're important. So in relation to implementing the toolkit in practice, we've been kind of going through this process of implementation for the last 18 months or so. So we've prepared resources for service managers and team leaders to introduce the tool and toolkit. We've done tailored presentations to team members. We've done the online webinars, and we've also kind of encouraged quality improvement activities as well, and looking at kind of measuring progress using data from client records, which Lauren will talk some more about.
So essentially from this point, we wanted to work out how to evaluate whether these resources were having an impact. So we worked with, the research team worked with Carolyn and Clara, a peer cadet, to come up with some evaluation questions, which were, do the resources support staff to have conversations with clients about their physical health, and do the resources enable clients to set goals and receive support for their physical health needs? So these evaluation questions helped guide the development of a program logic, which I'll talk you through now. So a program logic in this context is referring to understanding the theory of a program. So what activities are leading to which desired outcome, and what are the stepping stones between those two things. So I'll kind of talk you through the process now. So first up, we mapped out what the activities were, and I broke these down into the what and the how. So the what refers to the tool itself, the intranet page, the practice guidelines, the tip sheet for conversation starters, the webinar, PowerPoint slides for service managers, and then the how are the channels of communication to get that out to staff members. And then we have immediate outcomes, which are if staff engage with these tools, what do we expect the outcome to be from that? And we are predicting that it will lead to an increase in knowledge, skills, confidence to have those conversations, those supportive conversations with staff about their physical health, and lead to an increased intention to use the tool. And following that, we have intermediate outcomes, which we think through engaging with these resources, building knowledge, skills, confidence, and intention to use the tool, that it will result in an increased offer and increased uptake of the tool in practice. And then leading to our intended outcomes, which are kind of those larger desired changes, which our staff feel comfortable to offer and use the tool as part of their routine and ongoing practice, and clients are able to set goals and receive support around their physical health. So you can see how there's kind of assumptions made at every point here, which are based on, behaviour change theories like, theory of planned behaviour. Drawing on those, knowledge, skills and confidence being built will lead to increased offer, and, you can see how each is leading to the next thing. So from this point, we need to map the data sources to measure each of these outcomes so we can work out whether we're achieving what we're hoping to, and if we're not, at what point are we not achieving those outcomes. So that's what I'll talk through now. And this is all, I guess, within, a not-for-profit setting where there's not a lot of resourcing for elaborate research. So we're drawing on existing data to answer these evaluation questions. So if we first look at the immediate outcomes, which are those increases in staff knowledge, skills, confidence and intention, we're assessing those through a short survey among staff who have engaged with the tools. And that's through a survey provided at the end of an online webinar and distributed through email. So just a short survey to capture whether we're seeing those whether we're seeing high levels of knowledge, skills and confidence around having those conversations. Then for the intermediate outcomes, we're looking at increased offer and uptake of the tool from staff and among clients. So we're obtaining this through an audit of client records, and we're looking at what proportion of clients have a physical health tool completed pre and post implementation of the new co-design tool. So in 2019, when the old checklist was in place versus post implementation where the new co-design tool is in place. And we're planning on doing this for all client records that are available, but we're also doing a sub-analysis of residential services. As we know, there can be a high level of kind of comorbidities in those services, and with the kind of expanded service duration, sometimes it's more of an opportunity to implement some health promotion activities. And then lastly, for intended outcomes, this is about staff feeling comfortable to offer and use the tool as part of their ongoing practice, and clients are able to set goals and receive support. So there's two data sources going into kind of measuring these outcomes. The first is qualitative focus groups or interviews with staff and clients. And I think these are just some example measures we could be using, but I think it will be informed by some of the quantitative analysis we do as well. And then the second data source is an audit of My Better Life plan. So I think you might have briefly mentioned this. My Better Life is a goal setting tool at Mind where clients can look at various life areas and choose which they might want to set some goals within. So from this, we can look at what proportion of goals that are set are focused on physical health. And again, looking at the time periods of pre and post implementation for all client records, and also looking at a sub-analysis of residential services. So that's, I guess, the plan, and we're yet to complete all of that, but we've pulled together some preliminary results just focusing on residential services. And so this analysis is just based on adults in long-term residential services. So these are supported independent living services, usually 12 months or more. And I looked at for what proportion of clients did they have a physical health checklist completed in 2021 compared to after the new co-design tool was implemented in 2022. For what proportion of clients had a physical health tool completed then. And you can see there's a slight increase. This is just preliminary. Once we do some more comprehensive analysis, we might find different trends, but it's good to see in the short term that we might be getting a slight increase in the use of the tool. And then we've also looked at, from that, we are kind of thinking that there's more conversations happening about physical health using this tool. But this result is looking at for how many people in this same service are then setting goals using a My Better Life plan around physical health. And so this is looking at the proportion of total goals that are focused on physical health, and it's about 1 in 4 for that same service type. I will point out though that for the same time period, looking at the number of physical health tools completed, there was about 150, whereas there's only 35 people then using the goal setting tool. So already we can see there might be a bit of a gap in people having a conversation about physical health and then going on to set goals or, take further action. And that might be because the conversation was sufficient and they received self-management strategies that are working for them, or it could be that they might be missing out on that further support, and that's while we'll be doing the qualitative analysis and the further data collection. And I also pulled the same data for other residential service types. So we've also got adult and youth short-term residential services, which are prevention and recovery centres, or step-up, step-down services, which are about 14 to 28 days in length, and also youth long-term residential services to see what proportion of goals set in those are focused on physical health. And you can see it's far lower than the adult long-term residential services. Which could be, particularly for the short-term services, it could be a result of those services partnering with clinical partners who might take on a more active role in the physical health management side of things with allied health professionals involved. But it is interesting, particularly in the youth long-term residential services, that the proportion is a lot lower because obviously that's quite an opportunity to get in early with prevention with that type of care. So in summary, from those results, we might be seeing an increase in the use of the My Physical Health tool after redevelopment. Obviously, further analysis is needed to confirm that, but that's promising. Using the tool may not always lead to setting a specific goal around physical health from looking at, that number of people engaging in a physical health conversation versus setting a goal. And that's, I guess, shows the importance of the program logic and being able to pull that out even at this stage. and goal setting around physical health may differ by service type. And then I'll pass to Carolyn to talk through our learning so far.
No worries. So, so the things that we've learned so far is that involving someone with lived experience of mental health and physical health challenges early on really helped to shape some relevant questions for our evaluation. And so we pretty much adopted all of those questions and the phrasing verbatim. So we didn't kind of make any changes there. So I think kind of one of the other lessons that we've learned is about the importance of collaboration among teams and kind of using that shared expertise to problem solve. We'll be kind of speaking with the people, particularly in youth services as well, to kind of think to further understand whether the tool is meeting the needs of young people and whether it needs to be presented in a different way to better engage young people in those conversations. And also thinking about kind of how the environment is set up as well. So creating health promoting settings rather than relying on individuals to make goals for themselves. So that's something else that we can explore. Another kind of important lesson is about the use of existing data to evaluate knowledge translation. So through this the creation of the tool, we're effectively translating high-level policy guidance into a practical tool. We can see how effective that is through this process. Thank you.
We have time for one quick question.
Thank you for a beautiful presentation. I would like to ask, at what point in the care is this tool used? So is it part of your routine software that you use to assess patients, or is it an additional tool for the clinicians to use?
Mm-hmm. Yeah, that's a great question. So it's offered at two different points. So if someone kind of identifies that physical health is an area that they'd like to work on in their My Better Life plan, then they'll introduce the My Physical Health tool to have that conversation. And also the staff do like an assessment at the beginning of supporting a person just around what their issues are and looking at things like a safety plan and any potential risks. So if physical health conditions are identified as a risk, then we'll offer the physical health tool as well. So it's not mandatory, but it is offered a number of different ways for people. Yeah, so we've tried to kind of... Oh, yeah, sorry. So, the question was about how it's embedded into our software and data collection systems. So we've had to work with our business team to get that happening. Lauren probably knows more about how that happens at the moment. At the moment, it's manual. It's a manual interactive PDF that people fill out and then they put it into the data management system. So we're increasing in our levels of sophistication, but we're not fully integrated yet.
Thanks so much.
Cool. Thank you.
Thank you for that. That was another excellent presentation. Patrick, are you here? I met you earlier and now there you are. Okay, come on down, Patrick. Patrick's going to be talking about improving immunisation coverage with keeping the body in mind vaccines, a co-designed vaccination service for mental health consumers. So please join me in welcoming Patrick.
I got it here. Thanks. Thanks so much. Thank you so much. So I'm Patrick. I'm a mental health nurse working in South Eastern Sydney Local Health District as part of the Mind Gardens Neuroscience Network and now as part of the Keeping the Body in Mind vaccines program. Janine was meant to be here, who runs the clinic with me, but unfortunately she wasn't able to make it, so I'll be presenting on her behalf as well. So this is really an overview of a story starting from the beginning of COVID through to now of setting up quite a large-scale vaccination program that's ended up being co-designed It's from the beginning of realizing that vaccines were quite inaccessible for our clients and then working with them to develop solutions that work for them. So just in case everyone's pretty aware of vaccines now, but when we're talking about vaccine-preventable diseases, we're talking about any condition that can be prevented by vaccination, which is this big list here. And the ones that we're covering in the clinic that we're giving are there in red. So there's quite a lot of vaccines to give, which makes it quite difficult. They've all got their own different criteria. They've all got their own cost and different things associated with them. So navigating what vaccines you should have, especially if you haven't had catch up your childhood vaccines or aren't aware if you've had them, can be really difficult, as I'm sure any of you know who's had to go through that process within a health service to get all your vaccines caught up. So mid-2021, Equally Well put out the global consensus statement for fair and equitable access to vaccination for people living with mental illness and substance use disorders. And that was about the same time that I'd started running this clinic. So it's really good timing for me to have something to justify what I was doing. And this really highlighted that even at that early stage, there was really clear evidence of inequitable health outcomes and vaccination for this group. These are the results from New South Wales, which my colleague Grant Sara just presented 20 minutes ago in another room, which I was at. And so we looked at vaccine-preventable hospitalizations in mental health service users compared to the general public and found overall it was 3.2 times higher amongst that group. And now that's any mental health service user, not particularly severe mental illness or lots of contact. That's anyone who's accessed any mental health service during the time period. And we saw that it was, if you look on the left, that's the rest of New South Wales, and on the right is mental health service users. You can see that the risks are extremely elevated across all age groups, particularly elevated across men and also across females, but men particularly at a younger age than what is normally seen in the general public. And people are also hospitalized at a much younger age for all conditions as well. So they're younger and they're sicker when they're in hospital, stay longer in hospital, and are more likely to be hospitalized multiple times. So that's sort of background about why this is quite important. So to begin with, this is a question that I always get asked when I talk about this. I thought it's good to kind of cover it off the bat, is why this shouldn't be done in primary health and why we're doing it from the mental health service perspective. And there's a lot of barriers to accessing primary health generally for people with mental health, people who access mental health services. And there's very little to no incentive for GPs to cover this. It's quite a complex thing to do a full vaccine history. And so with everything else going on, with all the other comorbidities, bringing up vaccines is at the bottom of the list. And most of the vaccines that we've seen given were not given by GPs. The National Immunization Program itself doesn't cover people with mental illness as a special risk or high risk group, despite there's quite a lot of evidence that they should be treated in that way or that that's looking to change. But what this means is that there's no fee exemption for any of the catch-ups or flu or anything like that. So I had someone I was speaking to the other day who was getting their HPV vaccine catch-up, and it was going to cost $250 per vaccine for 3 courses. They couldn't give it out of the ones in their fridge, and so they had to go to the chemist, pay for it at the chemist. They had 15 minutes to not break the cold chain of the vaccine, to take it back to the doctors, to have it given, and no bulk billing for the whole thing. So there's a lot of difficulties in accessing it with primary care at the moment. In terms of COVID-19 at the beginning, people with severe mental illness were considered within a high-risk group, the same as healthcare workers, other than the healthcare workers in the emergency department. However, what we saw, at least with people I was working with, is they weren't being prioritized at all for vaccination. By the time we had all of our healthcare workers vaccinated, we had 1.5% of our mental health consumers vaccinated, even in the inpatient units. So it just wasn't being done despite the same risk categories. So we decided to do something about it. Me and one of the peer workers, Cheryl, and a few other clinicians in our own time at work essentially decided we should start our own vaccine clinic to cover this. So we went out, did the training, became accredited immunizers, and then began the long process of getting access to vaccines. We found, when speaking to consumers, that the drop-in clinics were actually turning them away. We found some drop-in clinics would accept people, then started getting buses and taking people to them, and then we were told, please stop, there's too many people. And the mass vaccination hubs were difficult for anyone to access, and they were quite far away, and there's a 3-month wait by that point. So we set up 2 drop-in clinics within community mental health centres in the eastern suburbs. So we partnered with the Kirkton Road Centre, who were already providing vaccinations to at-risk groups. They supplied us the vaccines, trained us in the model, and helped us run it, which was incredible. And that's a photo of us there during one of the clinic days running it with the team who were supporting the whole clinic. And this was all done kind of in kind, in addition to people's jobs. No one was released to do this. So it was really quite an effort. And Cheryl, who's there, was one of the peer workers who was really leading it, helping guide people through, having those conversations about vaccinations and making sure it was run in a really nice, smooth way. So from that clinic when we were running it, as you can see, these are the rates for mental health clients in the community mental health service. And when phase 1B commenced over there, that was when people were supposed to be prioritized for vaccination. And the rates for healthcare workers went, within 3 months, went pretty much up to 90-something%. So it was really quick. And we should have seen that in this group too. Then phase 2A commenced, and that was opening up to a lot of the general public. That made it even harder for mental health service users to access vaccines because there was suddenly massive demand, as most of you will remember. And so then we finally got access to the vaccines and got the clinic set up. And when we set up the clinic, we saw a huge uptake of, we administered around 600 vaccines, getting it up to around 82%, which at the time was only 6% lower than the general public, with other mental health services, when we looked at their data, was sitting around 30 to 40%. So we got it up really quick. And then when the boosters came out, we ran another kind of blitz clinics and got everyone done again and got it up to exactly the same as the general public, which meant that there was actually a higher proportion of people who were willing to be vaccinated generally had the booster. So amongst people who were vaccinated for double dose, those who had the booster was actually much higher than the general public. So a lot of people thinking that this is due to kind of symptoms of mental illness or paranoia or all those sort of things, we haven't really seen that. It's mostly around access and people coming to them and working with them. So after doing that, we essentially got some funding to create this as the Keeping the Body in Mind vaccines program, to get some more permanent funding to get this running, not permanent, but for a year and a half, to get this running properly. And to do that, we thought we should co-design it to make sure it was running in a way that would work for the consumers and involve them within it. So we ran a workshop with service users from all the way from early psychosis in age groups up to older person's mental health, and brought clinicians in there too from different services to make sure that we'd have their views on it as well, so that it'd be running in a way that works for everyone. And we've continued to keep these people involved throughout the process. They've attended the clinic, they've provided feedback on it since then as well, so to keep them involved as decision makers. The key findings were that with co-design, from the co-design, it was grouped into 4 different categories. One was promotion of vaccines, where we found that they wanted it to be opportunistic, so it's when people are ready, when they're already in the mental health service, be able to give it pretty much at any time that someone decides to do that. Also, you have co-produced pamphlets on myth-busting vaccine hesitancy, which we're working on making, but they're taking a bit of time to get that out there. It's a complex topic to write about as well. In terms of attending the clinic, this is the main thing that's really helped, other than having a peer worker that came up from that, which we hadn't thought of, was being able to bring a family, friends, key workers, or anyone who's with them to also be vaccinated, also for free. And so that works really well in terms of mental health clinicians would bring consumers along with them. They go together, and they go together to get vaccinated at the same clinic. So it wasn't just, you've got a mental illness, you're at risk, you need to be vaccinated. It was, let's go together to the clinic to have this happen. It was free for all consumers, and it still is, which we're very lucky to be able to have done, and to have home visits available for people who aren't able to make it to the clinic, which has been a bit tricky to get out there with all the oxygen tanks and adrenaline kits and everything, and it looks a bit intimidating coming up the stairs with that, but we've managed to do it for the people who need it. In terms of receiving the vaccines, have phone calls for people who want it. One of the things that's been really good, particularly at the community mental health centres, is to give the vaccines in the sensory room where people can sit there, take their time, they can wait in there if they need, with the massage chair. It's a much more pleasant way to receive the vaccines. And to give a colour laminated certificate that they could be proud of receiving the vaccines, which actually was a really big thing for many people. And people got really excited when we brought that out to them after receiving the vaccines, much more than I thought people would from getting that certificate. And for follow-up after the clinic, making sure we have assertive follow-up with future vaccine dates, particularly for vaccines that require several courses of a half a year, or that sort of thing, to make sure we're really assertive in helping people to come to the clinic, be aware of their appointments, providing a book with their appointment dates, and following up with phone calls, emails, texts, whatever works for them. So that co-design is now being rolled into the Keeping the Body in Mind vaccine service, which is rolling out that model with a clinical nurse specialist and a peer worker working side by side to run this clinic. Taking a full vaccine risk history, offering all vaccines as per the National Immunization Program for free in a way that works for mental health service users that they're comfortable with, taking the time to listen to them, to provide that education, and to work with them. And so it's been funded by this Central Eastern Sydney Primary Health Network through the Mind Gardens Neuroscience Network to run this within the South Eastern Sydney Local Health District, and looking to expand to drug and alcohol services as well to offer it to a broader group within this area. Now, it only started 2 months ago. We've managed to give 100 vaccines since its starting, which is pretty good considering it hadn't been running for a while and there's a lot of setup to get done, which is primarily at the moment COVID-19 and flu vaccines, which we've given. And you can see most of the vaccines we've been giving are boosters beyond the primary dose. We have given a few to people who were unvaccinated entirely for COVID, and this was not by choice. Most of them, when we offered it to them, people who are fully unvaccinated were actually really wanting to receive it and had been struggling to navigate the system, struggling to book in for appointments and to get that sorted. And flu vaccine uptake was primarily in those under 65. We found that actually a lot of our clients 65 and over were already vaccinated for the flu vaccine, which is a real testament to the older person's mental health services in the area for coordinating that. So that's the next steps, hoping to expand to other local health districts and test the scalability of this model in other areas. Thank you. Any questions?
Cool. Thank you for that. Very interesting presentation. Any questions?
Terrific idea, and thanks for the detail. I was just wondering, do you see sometime down the track and with appropriate work on it, it being applicable to more community centre kind, say safe havens or safe spaces?
Absolutely. I think that's the model that would be really good to work on for more long-term looking at this. At the moment, there's essentially a huge vaccine gap in most vaccines for all people, which requires a really big targeted effort to do a lot of vaccines and get that done. Once that's done, it's really just maintaining those vaccines with the yearly flu and COVID and things, which I think would be a lot better to roll out in centres like that, where it's kind of less just having it everywhere, but more routinely when people want it and having it like that. But the only model I've found of anyone else doing this was actually run, I can't remember what it was called, but in America, which was run by people with lived experience entirely in a centre like that in America, which had really good success rates. Any other questions?
That's for the people online. So, we're in no rush.
I was really interested that you said that it was about access rather than vaccine hesitancy. And were there instances where you did encounter that? And if you did, what were the strategies that were used around, I guess, education or?
Yeah, absolutely. So that, I mean, I've worked in some clinics that are for the general public too, and there's, the approach is actually really similar in terms of people who are like that, which was really you've got to make sure you've got the time to have those conversations with them and not push the vaccine then and there. A lot of people we've vaccinated, after the third time I've spoken to them or the fourth time and that sort of thing. But really, I mean, it's around getting past that stigma of someone being vaccine hesitant and seeing them as, they've got the wrong idea and I've got the right idea and I need to teach them that it's good to have vaccines. It's more about understanding why they're feeling that way and what they're really worried about. And talking to them about what's important for them has been really the main thing. And a lot of people have people who are at risk who are at home with them or people who they want to see. And so when they kind of talk about it like that, and they, especially with AstraZeneca, there was all those concerns about, this could kill me, this vaccine and this sort of thing. You talk about the risk of that, and you talk about, their mother who's 85, who's at home, who they look after, what the risk is for her if she gets it, and if it's brought home by you. That makes a big difference. But it has to be from a perspective of, I genuinely want to learn why they don't want it, rather than I'm here to teach you why vaccines are good. So, but it took a lot of work to get to that point, yeah.
I don't know how much overlap there is with people who were in this last session about human rights in this same room, but it just strikes me that this is a really good example of that applied right to health, voluntary, where the person needs it, where the person wants it, really kind of adjusted service delivery to the people, to meet their needs. I just think that's a nice follow-on from that session. Any further questions? Okay, thank you so much. I really enjoyed that presentation. Okay, our final, if I can find the right document. Which I cannot. Are you ready, Caitlin?
I am.
Okay, our final presentation for this session is Caitlin's talking about exploring and building the role of the peer workforce in supporting healthy lifestyle. Thanks, Caitlin.
Thanks so much, Chris. Hi everyone. My name is Katie Feely, and I am an early career researcher at the University of Newcastle. So I'm a part of the FEME research team that's led by Jenny Bowman, and all our research really aims to improve the physical inequity that's experienced by people with mental health conditions. And we have a particular focus on prevention. I feel really lucky to have the opportunity to be here today and to hear about all the fantastic work and initiatives that's happening in this space. And I'm excited to share with you a little bit about some research that we're just starting out on at the moment. Before I begin, I would like to acknowledge the traditional custodians of the lands across which we meet today and pay my respect to elders past, present and emerging. So the project that I talk about today is one that our team are currently working on that's supported by some seed funding from the Alive National Centre. And it's looking at ways to be building the role or looking at what the role is for peer workers in supporting healthy lifestyle. And it has a particular focus on smoking, nutrition, alcohol and physical activity. I just want to mention too, we're only just starting on this research, so we haven't finished it yet. So I'm just going to be sharing a little bit about how we've been going with it and some of our next steps. And I have already learnt so much today from some of the other fantastic presenters in this session and the other sessions today and the workshop just before this. So I can definitely see ways to be integrating that within this work as well. So although it's me presenting today, it's not just me doing this research. So I just want to acknowledge that there is a large team behind us who are involved, and just wanted to highlight a couple of the people, including people with lived experience, peer workers and peer workforce managers across the 3 local health districts that are collaborating with us on this project. So we have the Central Coast, Hunter New England and the Mid-North Coast. So I guess the reason behind this research is the reason that we're all here today to help address the physical health inequity that is experienced by people living with mental health conditions. And there are many, many contributors to that inequity that we've heard about today. But one of those is lifestyle behaviours. So things like those on the screen, so smoking, nutrition, harmful levels of alcohol consumption, not getting enough physical activity, and also poor sleep. So this research, and a lot of the research of our team, takes a prevention focus, so looking at ways that we can be supporting and encouraging healthy lifestyle for people with mental health conditions. So to do this, a lot of our team's work has focused on helping different services to be able to provide support for healthy lifestyle. So looking at the different types of mental health and other health services that are being accessed by people with a mental health condition, and looking at ways that we could be helping those services to be systematically and routinely including healthy lifestyle as part of the conversations that they're having with people and part of the and of course this is really important because I'm sure it's no news to anybody here, but we know that people with a mental health condition are very interested in improving health behaviours, and that they do want and expect to receive support from mental health services around this as well. But it may not always be provided, or there could be some potential to be increasing or improving access to that care. So some of our past research has involved working with different services and trialling some different approaches to increase the delivery of healthy lifestyle support across both government and non-government mental health services and in hospital and community settings. And some of the learnings from that work was around some of the different strategies that can help to promote practice change in this space. So things like tools and prompts that health professionals might be able to use, like some of the ones that we've heard about today, as well as training for clinicians to help increase their capacity in this space. So that's just, I guess, a bit of an overview of the kind of lens and work that's kind of come before this, which really brings us to the focus of this research, which is around considering peer workers as a really important part of that mental health system. So thinking about peer workers who bring their own experience, lived experience of mental health conditions, and draw upon that in their role in supporting people. Of course, the peer workforce is a growing part of the mental health workforce, and it's incredibly important to be considering their role as well in supporting healthy lifestyle. And of course, peer workers bring many unique strengths and skills to the support that they provide. So some of the things are highlighted on the screen here, for instance, around peer workers being able to be powerful role models for behaviour change, and able to understand and really respect the challenges that may be faced by the person that they're supporting. And the ability to walk alongside the person and share their own experiences to be building resilience, building a sense of connection and belonging, and empowerment as well. And there is some growing research now that's building the evidence base for peer-delivered interventions for physical health, including healthy lifestyle as part of that. So I think it was at last year's Equally Well conference that David Castle presented a little bit about this systematic review I've got on the slide here, indicating that peer-delivered interventions are helpful and can enable positive health outcomes for people, such as increasing physical activity. So I guess the next step now where this research comes in is looking at ways that we can be translating these positive findings into initiatives that enable the peer workforce to be considering healthy lifestyle or providing healthy lifestyle support. And so in this context, I guess the overarching aim of this research is around designing support strategies for peer workers to help enable them in providing that healthy lifestyle support. And the focus is on peer workers specifically in the government mental health sector. So again, just wanted to highlight the 3 LHDs that are collaborating with us on this project, the local health districts. So we've got, I don't know if you can see you can't see my mouse, sorry, but this is just a little snippet of New South Wales. So for those that aren't familiar, just to show where Hunter New England, the Mid-North Coast and the Central Coast are located. Okay, so this research involves 2 key stages. So the first is around, it's just understanding current practice. So thinking about what are the current experiences and perspectives of people accessing mental health services and peer workers about peer-delivered support for healthy lifestyle. And then this initial stage will then inform our second stage, which is where we're hoping to hold some co-design workshops to develop some suggestions and ideas for different strategies that might help peer workers in this space. So very much informed by what we've learnt in that first stage. So just stepping into each of those stages in a little bit more detail. For the first stage of the research, again, this is just our kind of current, our initial activities to understand current perspectives in this area and people's experiences. And so we're just partway through this, so we're just starting out. But this really began by having lots of group discussions with peer workers and people with lived experience, both together and separately. And then from that came 2 key research activities that we've started working on now. So some one-on-one qualitative interviews with peer workers and a survey of people who are accessing government mental health services. questions or key kind of parts of what we're asking people are just highlighted on the slide. I'll just go through them. So questions around, from peer workers' perspectives, for instance, what support might they already be providing in this space? How do they feel about providing that? So is it something that people feel confident and comfortable with doing, or is it maybe not so much? And then from the perspective of people receiving that support, what would they actually like to receive? What should that healthy lifestyle support look like, and what shouldn't it look like? And then if they maybe did receive some support from a peer worker, what did they think about it? Was it actually helpful? What were the pros and cons? What were the good parts of it? And just generally learning about some of the different values and benefits of peer-delivered lifestyle support. So as I mentioned, we're only partway through this stage, but I did just want to share with you a little bit about some of our learnings so far, and I'm sure there will be many, many learnings that we add to this as we go along, but really what's come through strongly is that people do feel that peer workers could be having an important role in supporting healthy lifestyle. And some of the reasons why really mirror what I shared earlier that comes from the broader literature, but it's things like the fact that peer workers help someone to feel understood so they can be relatable. And they bring that knowledge of the unique challenges that someone faces. So they might know, for instance, that it's not as easy as just getting up and going for a walk, or it's not as easy as just quitting smoking, and that there's unique challenges along the way. And also one of the other things that came through really strongly so far as well is the time that peer workers bring to that too, so that it's felt that they may have more time to be creating a space to sit with someone and to listen and therefore help. But it's also been raised that it's important to be mindful of each person's unique recovery journey and where they might be on that journey. So that's in terms of thinking about when healthy lifestyle support might be provided and what that person's individual goals might be. There's also been some differences among peer workers about whether or not this is something they might already be doing. So some people are sharing that healthy lifestyle support really is part of what they're thinking of, whereas for others it's maybe not so much. There seems to be a little bit of differences so far in what we're finding. But there has definitely been peer workers wanting more training and resources in this space. So particularly for people who weren't already providing healthy lifestyle support, wanting some clearer guidance about, well, what are the steps? What could that look like? What are my roles and responsibilities in this space? And there's also been some considerations raised so far. I guess this will probably come more into the second stage when we do some workshops, but just so far people raising, for instance, that there might be differences in people's experiences that could impact here. So people having very different experiences of mental health conditions or different health needs. So for instance, a peer worker might be supporting someone who is wanting to quit smoking, but the peer worker themselves isn't a smoker or hasn't been a smoker before. And so I guess that might impact their ability to provide support that's informed by their lived experience. And so one of the suggestions that's come from that is maybe there could be some matching of people based on similar experiences, but I'm sure that will kind of come out more as the project goes forward. And I guess just acknowledging too the importance of ensuring that whatever's developed is consistent with the defining features of peer work and not moving to a more clinical approach to healthy lifestyle change. So once we've completed that initial first stage, learning about current practice, the second stage will be to hold a series of workshops with peer workers, people with lived experience, and possibly also some peer workforce managers as well, to consider all those findings, all the learnings from stage one, to help us interpret and understand them. And then to, number one, be thinking about, well, from that, what should peer-delivered healthy lifestyle support look like, and consider what that might involve. And then 2, what strategies might help enable the peer workforce to be providing that support. I put some examples on the board, but I guess we really don't know what these might be yet. It could be things like training, resources and guides, but they're just examples. So where to from here? We're really hoping that this research will contribute to recognising and building the role of the peer workforce in mental health settings, and could possibly lead to some future research around trialling and evaluating what is co-designed in those workshops, thinking about whether they might be effective, for instance. But we're very much hoping to write up the results of this research when we finished it into a publication and be able to share that as well. Thank you so much, everybody, for the opportunity to present today.
Thank you. Questions?
I have lived experience, and I'm very interested in lived experience driving a lot of these programs. But I'd like to ask, say with exercise, if you're encouraging, do people need to be checked out by an exercise physiologist or a clinical person before they start an exercise program? Or would the peers just say, well, start walking, or maybe you could start dancing, or how does it work in that way?
That's a really good question, and it's I think part of what we're still yet to work out and falls into that idea of where do the roles and responsibilities of people lie and what are the roles and responsibilities of peer workers here. I think from what we've heard so far, there's definitely potential for peer workers to be able to be recommending at least connections to people who might be able to facilitate more specialist advice if that's needed. But there could be some, we've already heard about some great initiatives that are being ran and walking groups and things like that that people might be able to be connected with that are already kind of happening. But yeah, I think that's a good question and relates to some of the other behaviours as well. So not just physical activity, but things like nutrition too. Sometimes people might need a little bit more specialist advice from a dietitian, for example.
Hi, Megan. I'm really interested in the, following on from that question, the ecology of this, right? So, like a government-based peer support program that is socially prescribing things, right? So, how does it fit with, say, if we do, if we're following ABCD stuff, you've got walk and talk, you've got, boot camps, you've got social enterprises that offer stuff. Could it fit into that landscape and provide, close the equity gap between people you pay for things? Or would it be like government standalone with a higher risk profile and sort of referred to from a clinical point of view?
So I think if I understand your question correctly, sorry, it's around whether this could be integrated with some of the programs that are already existing or happening in the peer.
So communities have programs.
Exactly.
Yeah, that cover a lot of this.
Exactly, and I think that's the hope, that we can be, this might be something that isn't, I guess, an extra standalone thing, but something that's integrated and considers what might already be out there, what could people be connected to, or increasing awareness and access of those different initiatives and helping people, assisting people in accessing those for sure. So yeah, not thinking that this would be like a really specialist program or initiative, it's something that could be I guess, offered to as many people as possible and about increasing that access to healthy lifestyle support.
There's one on the other side of the room, isn't there? Just make me walk all the way over there. Yes, get my steps up. Yeah, good-o.
As a fellow Newcastle person, I find it really interesting philosophically that we might be asking peer workers to, in a sense, start an intervention. it's interesting space to be in, and whether or not that actually is the role of peer workers. But then you could say that maybe recovery, physical health, is part of recovery, but then we need to work in the lived experience space because it isn't. We don't think of lived recovery in terms, as much in terms of physical health. Just a floating comment.
No, thank you. That I think is a really good consideration and reflects, I think, some of the discussions that we've had so far with peer workers in ensuring, again, that aspect that this doesn't deviate from what peer work is and always being driven by what the person's goals are and what they would like support for sure.
Thanks. Sorry, just as I guess kind of like a follow-up to that, I was just interested in finding out where the peer workers were actually working. Are they working in acute units? Are they working in inpatient or in community? And what proportion? Because I think that would also have an impact on the kind of strategies that they'd be able to use, or even if that is actually part of their role.
Yes, that's another great question. And yeah, it is a mix at the moment. So we have peer workers who are working predominantly in an inpatient setting, or people who are providing support to people after they've been discharged from a hospital setting. So they might be supporting people to be accessing other community supports after they leave hospital. And then we do have people working purely in a community setting as well. So it's very much a mix of different perspectives. And I'm hoping once we get some more more perspectives and more people involved, we'll be able to tease apart a little bit more some of those differences and what might work better in different settings.
One more question. It's all the way up the back, of course.
It's a comment more than a question. Having been a peer advocate or worker since 94, I go to a person and say, what do you need and how can I help you to get there? If they say they have physical, if they're not happy with their physical health, then I'll connect them with a clinical service. But that is not my role as a peer worker. My role as a peer worker is to talk to the person as an equal and say, what do you need? If I come in suggesting what they need, I'm going from that top-down approach. And that's not what peer work's about.
Okay, thank you everybody for maybe join me in thanking Caitlin for that excellent presentation. That's it for this session. We are back here in a certain amount of time that I don't have in front of me. Thank you for your attention. Thank you for your participation. And we're back in here, though, in this same auditorium in whatever amount of time it is. So thanks again. Digital guide. Like, you send me a video, I can embed in the PowerPoint. Yeah, okay. All right. Yeah. And I'm probably going to come in early. maybe we can have it play through.
So to use the mouse, I'm here. So people can see me pointing by the mouse. Screen for a particular reason. So unless you go, yeah, you see how the mouse goes, but it's, the mouse is on that screen, not this one. Okay.
There's no like speaker notes or anything for the close of the day because it's supposed to be just the
No,
wrap
so
up.
we'll
Isn't
just
it?
get back up. We'll just get back to finish and just thank everybody and remind them about the function.
Of course, for those who have RSVP'd, is it? I don't know if we have capacity for people who haven't RSVP'd but decide they really want to go.
People will just come anyway.
So, yeah, yep. We've got a couple of minutes, don't we? It's
Oh, let's start now.
Oh no, right, okay. A bit of a chat. Phones, microphones. Are these rooms okay? All right, we might get started back up before we run over time. Otherwise, we'll be finishing late and everyone will be very upset. Welcome back, everyone. I hope you all enjoyed your breakout sessions. For our last formal speaker for today, I would like to welcome back to the stage distinguished Professor Richard Osborne from Swindon University of Technology. He's going to talk to us about why and how to use health literacy development to improve health and equity in the mental health sector. Now, you've seen Richard before today, but Richard Osborne is a professor at Swindon University of Technology in Melbourne, Director of Centre of Global Health and Equity and an advisor to the World Health Organization. He works in areas such as epidemiology, health services research, implementation science and health policy. For most of his career, he has held prestigious Australian National Health and Medical Research Council fellowships that have focused on research methods that accelerate innovation, implementation and equity. For the past 10 years, his team has had far-reaching international impacts on the field of public health, particularly in health literacy development. His team has developed health literacy surveys that have become widely used, including national government surveys. His health literacy questionnaire, HLQ, has been applied in over 700 studies, including population surveys in Australia, New Zealand, England, and France. His team developed and implemented new community-based co-design methods to build and scale up public health interventions. The most widely used method is called the Ophelia, which is optimising health, literacy and access process. Ophelia was recently highlighted by the World Health Organization as a process to accelerate impact on non-communicable diseases and health equity globally. With WHO's global coordinating mechanism for the prevention and control of non-communicable diseases, Richard's team developed the concept of health literacy development, which is included in WHO's recent health literacy centrepiece, which is a 4-volume report on health literacy development for the prevention and control of non-communicable diseases. So this, what to do and how to do report has been classified as a global public health good. That's amazing. He has over 300 publications in international scientific journals. Many of these papers have been widely read and cited, having been cited over 50,000 times. That's amazing. Your impact rating must be off the scale. Grant bodies must love you. No? So over 50,000 times. He's been named as a Clarivate, highly cited researcher in 2018 and 2021, which is an award given to the top 1% of most influential researchers globally. That's an amazing achievement. Welcome, Richard. CT Standy?
Maybe I'll... Thank you for that kind introduction. Of course, I wrote it.
Well,
Regrettably, I gave the wrong one. How boring for you to go through all that. I'm sorry. Sorry to put you through that. It's very tedious. I have this habit of speaking really frankly, and it gets me into a little bit of trouble. But oh well, I've survived this far. I'll try to keep going. But it's really, I'm on the side of hopefully on having an impact. And as I mentioned in the earlier on, and certainly in the workshop, I'm dyslexic, and I've grown up. Well, I grew up thinking that I have a lot of evidence that I was stupid, but for some reason I never believed that. And so I kind of have a French judiciary approach, a French legal approach, that everything is wrong until proven guilty. So, like, I don't believe anything. I don't believe a lot of my own work. And a lot of my own work, I don't like to give it to anyone else until I'm absolutely sure it's useful and will have impact. So I think that's the reason why my work has been taken up, because it's typically, I try to make it useful. But I must say, there's very few times I've changed my presentation so much as what I have today, given all the extraordinary presentations earlier today, all the concepts, and just trying to make it, again, useful. And hopefully I've hit the mark. We'll see. All right, great energy in the room. What a great symposium. Let's get going. I'm going to tell you about my dream first. This is an interesting way to start. My dream that all public health interventions are co-created with community health professionals and other stakeholders. That all public health interventions are developed based on unbiased and well-characterised needs of those we're really trying to serve. We have implementation and scaling up strategies that was integral to the design. All public health interventions are so fit for purpose, they get sucked into practice and evaluated for impact. Impact on people's lives, that people's lives are better. That actually the research that we do it's evaluated for that actually makes people's lives better. And can be implemented equally well by non-expert and expert groups. Wow, what does that one mean? That us academics develop something that can be easily implemented by anyone in the community, anyone in health services that just want to get on with doing good work. So getting research out of the ivory tower, getting good method, making methods egalitarian. All right, that's my dream. I'll show you how I'm trying to go around getting this done. But what is health literacy? Health literacy is a way to understand what are people's health information needs, why some people struggle to look after themselves, why adhering to medications and lifestyle change can be so difficult for some people. what we need to do to improve service quality and effectiveness for all people. Why many of our interventions are so ineffective. Well, they're effective for those people they're effective for. They're effective for those people they're effective for. They're easy to reach often. The ones we make it, co-design it with, who are easy to have there around a table at that time. And it's much more than that too. That's just a start, perhaps. But actually, most of the research we do is not reproducible. 80% of what we do just doesn't get reproduced, doesn't get used again, is not usable, can't be used. This is well shown in preclinical sciences in the laboratory, but it's also the same for public health. Why is that? Well, it's because we don't really release stuff until it's really, really ready, until it's actually fit for purpose. We don't really know what reproducibility is. We don't really care about it in public health institutions because the drivers is for publications. The drivers is to get more grants. The drivers is for your CV. So we don't have really great drivers to have real impact. Is my research reproducible? Well, actually, I found this article because this extraordinary man, Glenn Begley, published this article in Nature, and he gave this presentation about reproducibility. It stirred me up so much. And I realised the mentors I had growing up in my research career were also obsessed with this. So I happened to be tremendously indoctrinated into reproducibility. Does this matter? Of course it matters. It matters a lot. We're using public and private monies all the time. We must do this much more responsibly. So how are programs and policies usually developed? Is there a particular method? Has anyone done a PhD in intervention development sciences here? Is anyone? A PhD in intervention development sciences? Or a master's? Short course? Has anyone ever heard of intervention development sciences before? Two. So, okay, I'm an epidemiologist, I measure stuff, okay? We're getting pretty good at measuring stuff. We measure stuff all the time, we measure it. And then we're good at evaluation. Yeah, we do randomized controlled trials, we do program evaluation, maybe there's realist evaluation now. We can evaluate things. What about this thing in between, the thing that we actually want to implement and evaluate, the sciences around that? So that's what I've been working on. Let's actually develop things that are fit for purpose, wanted, needed, and implementable. So yeah, let's use method to make things more useful for implementation for both programs and policy. Okay, top down, bottom up, my diagram. I'm still working on this diagram, how to communicate this as well as possible. Top-down approach isn't really good enough, is it? We know that. But we could say the bottom-up approach isn't really right one either. So with the top-down approach, we've got governance, which is distal from diverse communities. We've got leadership and improvement based on prior evidence. It can protect the community from known harms and implement known benefits. Magnificent things can be done, like seatbelts, fluoride in water, mass vaccination. We can do really great big picture things and be tremendously effective, but all the easy things have been done now, haven't they? There's potential for magnificent universal impact, but community engagement and implementation can be disconnected from what's wanted and needed. So a top-down only approach by governments and organisations isn't quite right. Then we've got the other side here, the bottom-up approach. Grassroots movements can be transformational, but participation and engagement can be really fragmented. It may not be everyone in a community. It could be just fragmented groups or particular lobby groups. It can be uncoordinated, not representative, and disconnected from policies and processes. The community activism and advocacy can mobilise resources, change policy, generate much needed change, absolutely can have tremendous impact. Thousands of examples around the world. But the governance is distal from the diverse communities again, because what the communities want to have in place may be so different than government priorities, what's possible, what's needed and wanted at that particular time. So we need to have something in between, don't we? We need a top-down and a bottom-up approach. starting at the top, we need governance coherence between community needs, implementation capability, and political imperatives. And the bottom, coordinated and meaningful engagement with implementation across diverse communities. And in the middle, policies and programs match to what the community needs, wants, and can be implemented. So that's kind of what I'm thinking through of how can we get this green thing happening usually. It takes a lot of coordination. So we've had a little bit of success over the last 10, 15 years with developing the Affiliate Manual, the Optimising Health Literacy and Access Manual for locally and for WHO. Then we developed national health literacy demonstration projects that have been going for a while. There's a few of those around. And we were able to do this terrific program with the Mental Health Commission in New South Wales. I'll go through that a little bit later. And then we re-released the Affiliate Manual last year. We have this terrific report with WHO. And the French government now taking on my recommendations from the WHO report. And there's a new European Commission project, which I can't talk about yet, but it involves a lot of countries at once using this methodology, such that across the whole regions, we begin to see what is sensibly scaled across regions, what should be focused on particular target groups like migrants, and what should perhaps be sensible for sub-regions. If we can have large enough programs which all developed and evaluated using really clear methods that are seeking to develop something which is implementable and scalable and equitable. So that's part of the breakthrough and some work that's coming up soon. A little bit more on the WHO report. There's a QR code if you want to get a copy of that, but these slides can be easily made available to whoever would like them. And the demonstration projects, the first 16, and then there's some new ones, and there's some upcoming ones in different parts of the world, including that big whopper in Europe. Okay, and now the demonstration project, as Catherine said this morning, is one of the demonstration projects. Okay, a simple key concept, a few concepts I want. Listening, as I mentioned this morning, I reckon listening is really hard. What ears am I using today? What biases are in my ears? What indoctrination I've had through where I happen to be brought up? We all have these. So listening isn't so easy. And we're trying to engage with people, telling them that their diet's bad, they've got to be healthy, but they always live in a smoggy area and they're just worrying about enough food on the table, these social determinants of health. All my friends drink, so you're telling me not to drink and not have friends? So people are just having a life. They're just having a life. And we're telling them, no, you've got risk factors. We're seeing the world through our lens because we have this obligation, this role as health professionals, but it's not necessarily people work. And then we're trying to get them to box themselves into a particular incomprehensible NCD or non-communicable disease. But some people are aware of these links. Other people are not, or they may see a connection, but it's pretty complicated because they happen over a long period of time often. Some people can be completely unaware and reject. So we're working in this really interesting area where we're the health professionals and we're not really able to communicate in a language which really makes sense. And then we've got these diseases which make no sense or may not happen in the future. So I need to get a little lozenge. So you can take over for a bit?
Sure. Speaking from my vast experience as not a clinician or a researcher or an academic, I feel like I can speak as an expert to Richard's work. Are you regretting handing the microphone over yet?
Not at all. I'm trying to have my work be egalitarian and anyone can use it.
Well, it's definitely that.
Right. Applause, please. All right. I was thinking before I started this session, this is the worst session. People, it's the end of the first day, they've travelled here, it's really tough. Anyway, I'll try to keep you going for a while. All right. We've got health literacy of individual. We have community health literacy, and we've got health literacy responsiveness. There's 3 types of health literacy which we defined. Obviously, a person's health literacy is really important, no doubt about it. Irrespective of whatever health literacy a person might have, we need, as health system, health services, health practitioners, carers, friends, to enable people to have the best chance, irrespective of what they need and want and their capability. But then, of course, it's all that people around, all those resources around the people. Many people in society are not making their own decisions, are they? They're making decisions with their family, with their friends. Maybe it's the village matriarch. Maybe it's grandmother, grandfather. So a person could have very low individual health literacy, but they've got amazing community, amazing friends, amazing support, amazing GP, amazing friend down the road. So it's pretty complicated, this health literacy thing, actually. Most people live not in individualistic societies like Australia. They live in communal societies. So individual health literacy overall is perhaps something pretty unimportant. Overall, globally, 7 of the 8 billion people live in communal societies. And many people in our society are making community decisions. People support them all the time. Some people really, really want their GP to make that decision. And that's the right thing for them to do at that particular time. There's about 5 types of health literacy. We categorise them: accessing, understanding, appraising, remembering, applying. I have 2. So people can have a lot of tasks at different times. Remembering doesn't often appear in the list, but I think it's really important. People have got to remember the right thing to do at the right time. So there's quite a lot of work to do for people. I think we need a really well-considered mix of interventions that to make our work effective for disease prevention and control. How do people actually learn? No, I learn differently. Some people love printed materials. Some people only want to learn by talking to health staff. Some people, it's through media, TV, radio. Community conversations, talking with a peer group. Maybe it's the Iman, which is the most important. Then through social media apps, or arts and songs can be the most important for some people. And all these might be right for some people at some time, but not other times, or the right mix. And yet, most governments put out more 1 or 2 of these. It's easy, it's quick, looks good. This is a really useful framework. So when we're developing interventions, why don't we just look carefully at the task that's going to be done and look at the kind of materials, the learning styles. These are classic learning styles. Just this alone can produce really, really greatly improved education materials. So I won't go through this in detail, but just to say what people are talking about over dinner or down the pub or wherever, it's incredibly important, the community conversations. We need to use this and build on that. Simple message: when developing services or engaging with people about their well-being and their illness, or both management and prevention, use health literacy thinking, please. How people learn, the health literacy tasks, the daily health literacy skills and ability. So we had to measure this, so we developed a way of measuring it, which I mentioned before. So, which is embedded within the Ophelia process, optimising health literacy and access, really trying to connect health literacy thinking to people at all levels of community and co-design, prioritisation, implementation of locally designed fit-for-purpose solutions. It's got 3 steps, which I won't go through in detail. You'll expect to see these in any kind of sensible research program, except we use this very careful process of assessing the mechanisms behind why people might be struggling, or the mechanisms by which they can do some things sometimes. A key point here also is that this tool is a strength-based approach, recognising that some people have strengths sometimes and not other times, but we've got to build on those strengths. Here's the questionnaire, 9 scales, fundamental things. I won't go through many of them, but feeling supported, understood and supported by providers, or social support for health, appraisal health information, ability to find good health information, understanding health information well enough to know what to do, some of the things. So people can have a great mix of these, and we developed a questionnaire, and those people who love questionnaires would recognise this is a pretty special questionnaire. In many languages, we're finding it is more than robust, used in many places. So the Ophelia process is used to develop the mental health literacy project here in New South Wales, in partnership with my university, with the University of New South Wales and University of Newcastle. Some of the people in the room were involved in this, so you could wave at me, and if you're still game, it was a really hard project, a really tremendously hard work. So we're able to get immense amount of data from people, from their hearts and minds using this questionnaire, which have questions which come from the hearts and minds of ordinary people, about ordinary things that people do in their life, not for some interesting academic theory, but actually what's useful for people. This pretty diagram here, this stoplight kind of activity, it's what we have here is different subgroups of people going downwards on these columns. And this is where subgroups of people have been put in the same group with pretty much the same scores on all 9 scales. It's an old-fashioned cluster analysis. Every time a clinician sits down with a client, a patient, they're trying to find out, what's all the special features of this particular person? I need to get my repertoire going. I need to understand who are they? And I'll think about all kinds of people like this I've seen in the past. Yes, I've seen something like this before, and you come up with a solution. So this is a bit like that. Subgroups of people with the same sets of skills, and each of these people need a different kind of solution in some ways, don't they? Because they've got different strengths and different weaknesses and preferences. So here's just one example, the second most challenged person, I guess. So they have also linked to a particular lifestyle. So we actually get a very detailed profile of lots of subgroups within community. And here is a vignette developed from that particular profile called Matt. We give them nice names. We co-design these with the community to make sure they are actually meaningful, short and succinct. Sometimes we're able to make them into videos, entire videos, which are incredibly educational, incredibly emotive. People in the workshop got an opportunity to see this. So I've got several videos. Then we'll ask the community, and these small workshops with quite often with 5, 10 people, and people will often have a wide range of lived experience. In fact, COVID kind of helped us because people were online, very diverse, all kinds of issues, all kinds of places and conditions. And people can veto. If they don't like a video, they can, a story, they can, if it's too stimulating or problematic, or it's too close to the heart, they can skip it and they can just go on to the next one. So we ask, first of all, do you recognise this person in the community? What's their main issues? Develop a relationship. What strategies would be used to help this individual? So a community member is asked to use their lived experience. They're looking at the lived experience of someone else and they're just reflecting on their own lived experience. They're using their own expertise, exactly what they've seen in the community around them. We're not asking them anything fancy, nothing academic. Do you recognise this person? Oh, it's like Uncle Joe, he did this. Well, it's like me sometimes. So it's just ordinary people, and in here is embedded those health literacy mechanisms. So we ask, what strategy to help this person? Then if there are lots of people like this in the community, what could you do with lots of people like this in your particular organisation? Because then we get the meta thinking, the systems thinking. Then we get hundreds and hundreds of ideas, and we can organise them into changes in individuals and changes that have to happen in the community or in the family, or changes that health staff have to do every day, or changes in policies and programs. So we get really rich detail on how to build a solution across the entire system on the table with the lived experience of people in there on a daily basis, and also our best frontline practitioners, those extraordinary practitioners who really have seen thousands of people come and go, and often people never really ask them to engage in a clinical case like this or a community case like this, where they can really share what they do on a basis. So just the workshops themselves, incredible learning experience for our clinical teams, and often our community members want to be part of the solution. They're so inspired by the ideas they get. The first time I ran this was in Northumbria in England for some reason. And they got aggressive at the end of that. They were so inspired by the ideas, they wanted to be part of the solution. They didn't just want to give the researchers their ideas, they wanted to be part of it. So in developing these sort of interventions, there's always something in the middle which has to be there. It's going to fall over unless we have it. But then there's all this stuff we have to modify around it each time. But in developing this New South Wales Mental Health Literacy Initiative, which was with the 10 PHNs, very, very different organisations. Very different. All kinds of levels of interest, of all expertise in some areas of health literacy or not in others, and all kinds of maturity. So we had a very complex project. So how do we find the most important things for all these PHNs? And yes, very different organisations serving a lot of people. We're really seeking to upskill the healthcare professionals right across the state, particularly through PHNs, so that they can improve services and systems systematically. And this is a program logic for those people into program logics. We really try to systematically understand what's going to happen right at the top, right at the top. People who have lived experience of mental health issues and caring families and kinship groups. Everyone. Bottom, that people of New South Wales have the best opportunity for good health and well-being and to live well in the community on their own terms, having the service and supports they need to have a full life. That's key directions of key policy document, the Mental Health Commission. So that's what we're aiming for. So what we have in there is stuff that is at the organisational level, stuff at the individual level, and the responsiveness, the matching between what we need to generate the organisation such that we get these changes at the individual level. We built 11 action areas in 3 main groups. Action areas focused on connection between health services and community. Action areas focused on accessing help at the right time in easy, friendly ways. Action areas focus on training and capacity building in health and community services. And there's 11 altogether, and there's actually one also about young people in schools as well. So this was what we generated from an immense number of ideas across New South Wales. From a co-design process where practitioners and people with very diverse lived experience in their carers just put on the table what they think the solution should be for those cases like the MAT. I showed you that little vignette before. Lots and lots, hundreds and hundreds of ideas. And we just organised them like this and checked that they all made sense to them. Under each of these is a long list of how it can actually be done within organisations. So this is what we're putting into a software package for a quality improvement services tool to enable organisations to easily assess and work on one of these or all of these at the same time, or what do they need to do with their organisation. Okay, so we're able to finish our program logic with the mechanism inside, and we're able to do a 3-point transformation program, orientate your organisation, evaluate your organisation, implement training. So lots of lovely videos with local famous people or other people, and lots of vignettes to use too for really to get grounded experience. This is built for a whole wide range of practitioners' services across the state. Okay, I won't be able to go through this in details, but all these 11 action areas have lovely material on them of what to do on Monday morning, practical stuff. Implementation on this, we did about 40 odd different kind of education training kind of ways in which organisations can use these on a daily, weekly, monthly, yearly basis, focusing on what they particularly think is needed or useful by them. So using good educational processes, standard educational processes of really having key learning outcomes and learning processes that practitioners and trainers could use on the day, whenever they need. So I think I'm coming towards the end. It's going to look a bit something like this. So watch this space, keep ringing the Commission and support them to keep pushing us to get it out there and work with you. I won't go through this, but just in summary, we really do try to have a strongly principles-based approach. We don't do projects, we don't do pilots, we don't really do programs. We really seek to do transformation. So day one of our projects is day one of scaling up. So we have a very deliberate program to make sure that every step is supporting us to have the material so this could be scaled up. Okay, this is my dream again. So this is my second last slide. So this is the sort of stuff I'm trying to do, that we're doing. Lots of great collaborators from all around Australia and many parts of the world now, really trying to build and improve how we do public health, improve services and health service research. Thank you.
Actually, yes. Do we actually have time for a couple of questions? If anyone would like to ask Richard a question? The pressure, it is getting to that time of the day. Well, oh, here we go. Welcome.
I was speaking with some senior person from diabetes in Denmark, and they said, this is what we want to do. So this is absolutely built for a person, no Cartesian divide. This is a person who's trying to have a life. They've got a mind and a body. So these are fundamental things. So I would see this, hopefully is relevant far beyond mental health, far beyond. So thank you for that question to highlight that. Deserved a break. Oh. Just to repeat the question, the WHO has been criticised for being very medical. And not being responsive, and a whole lot of other things I could add to your list there. With this particular report, it is transformational. We're able to say that there's the WHO best buys, which are very medical, all this evidence around, all this proven, all these randomised controlled trials, but they're designed for Mr. and Mrs. Average, for want of a much better term. And they will, by definition, increase inequalities and leave more people behind. So at least this one report in WHO, which is getting traction, is having impact. At least this one. But there are so many complex drivers, so many medical imperatives. It has a long way to go. They do have good strengths in really trying to have nursing as an immensely important, community nursing globally, at pushing great things. There's many incredibly good things they're pushing. But it is a slow organisation, and it's not designed. It's designed to respond to countries. Doesn't have any teeth of its own. It's supposed to respond to all the requests of countries. So if we could get our government and many other governments to take a much more sociological and community approach to health and demand that of WHO, then WHO must change, because that's how WHO works as a UN agency. Interesting question. Great questions. Thank you. Oh.
Be really interested in your experience on the importance and the role of language in transformation, and how you've dealt with that aspect of the transformation process.
Oh, this is a fantastic question. So you wouldn't have. Did you know that I've chaired 300 translation meetings for most of the languages in the world. The thing is, some countries, they can't get irritated because they don't have a word for irritation. How can you get irritated? There's no word for it. I'm sure there's people here from many other language groups. So with the Australian community, I can only listen with the kind of Aboriginal community with their language. I can only listen from the words and concepts I have. There's a whole lot of words and concepts that they have that I can't communicate to me because I can't hear them. So that's a really important issue. But I think one of the common things in humanity is being connected and being seen. So there are many, many common things. We've just got to recognise some of the mechanisms in the Western world just don't exist in other countries. So I've just spent 6 weeks in Senegal, in West Africa, really trying to understand what is their agenda and what's important to them on a daily basis. I've done this with travellers or Roma people, gypsy groups is politically incorrect term. What's important to them? Family and dancing and love. And we have our agendas as actually communicating in a way in which we use language not to put our power upon people, but actually to give power away. The more we can give power away and have the agenda to be the other groups, the more we're going to have impact. But that's so hard for academics. It's so hard for medical people because they take so many years to become so important and powerful, etc. There's so much work has to be done on how we engage communities such that we give power and authority away for actions to be taken. So it's very much about languaging, and that we just, in the West and the British West, we don't have languages and ways of giving power away because it's not part of our common vernacular. Oh, great question.
Thank you. Hopefully relax now. Thank you so much, Richard. We were talking in one of the earlier breakout sessions about the importance of health literacy, because you'd mentioned it in the panel discussion. And I think of so much of my experience in mental health services are based around power, because I didn't know enough to know what to ask and what to talk about. I had to rely on the experts' priority areas rather than what I found important. And the only way I've been able to correct that is through educating myself. That individual health literacy and community health literacy is so key in sort of equalising that power imbalance. Thank you, Richard. Look, tomorrow morning we will be starting at 9 o'clock sharp. We'll try and get a really sort of punctual start to the day. The building will be open, I think, from 8:30 or 8:45. So caffeinate up and come along. Please don't forget we have a networking function for those who have managed to indicate they would like to attend at 5:30 today, so in about 15 minutes, which will be on level 1. And that evening we will be hosting, but it has been sponsored by Queensland Health, so thank you, John. Not you, no, you can't claim credit. Look, we have had an extraordinary first day of the Equally Well Symposium for 2023. We've had some amazing speakers that have shared some really rich knowledge and provoked some amazing discussions. Oh, excellent. We have capacity with a last-minute cash bonus to give flexibility for people who haven't been able to RSVP but would like to attend the networking function. So please come along upstairs, level 1, up the top of the escalators. So look, we have had an extraordinary first day. Very unfortunate that we were rudely interrupted by the emergency evacuation and forced to wrap up a really great speaker in the form of Debbie Hamilton. I would have personally liked to have heard more about how you were going to finish up talking about sex. But look, it's been really rewarding for me personally and really gratifying to see the engagement and the enthusiasm of everyone here and everyone online, of course. It's the ongoing interest and enthusiasm and the willingness to engage that really makes the work that we do possible. And for that, you have my utter gratitude. On behalf of Equally Well, thank you very much for a great first day, opening of the 2023 Symposium, or 2023. Gosh, what am I doing? Thank you.
Well, you could be the tandem speaker.
Yeah, my ad-libbing is not the best. Sure. Successful day. Should we leave this? Can we trust to leave this, or do we want to take it away?
Do you want to be entrusted with it, or do you think or you want to leave it?
Let's check with the boss.
Ask the boss what we should do, and that's other stuff.